शुरू करेंगे ना। नमस्कार, सुप्रभात। माननीय अतिथि पद्मश्री डॉक्टर अभय बंग, डायरेक्टर सर्च, डॉक्टर सत्यदास, सीईओ IKB नॉलेज पार्क हैदराबाद, निदेशक CSIR-CDRI तथा सभागार में उपस्थित सभी साथियों। तहकीक की शमा जो 75 साल पहले जली, आज भी उसकी लौ उतनी रोशन चली। आप सभी का CDRI के 75वें वार्षिक दिवस तथा प्लेटिनम जुबली समारोह के इस गौरवपूर्ण अवसर पर हार्दिक स्वागत, अभिनंदन एवं वंदन है। आज का दिन अत्यंत महत्वपूर्ण है क्योंकि आज हम CDRI के 75 वर्षों की मेहनत, समर्पण और वैज्ञानिक उत्कृष्टता की प्रेरणादायक यात्रा तथा प्लेटिनम जुबली समारोह मनाने के लिए यहाँ एकत्रित हुए हैं। यह हमारे लिए अत्यंत हर्ष का क्षण है कि हम इस सभागार में हमारे साथ इतने विशिष्ट अतिथि मौजूद हैं। आइए जोरदार तालियों से इस ऐतिहासिक समारोह का शुभारंभ करें। धन्यवाद। अब कार्यक्रम की औपचारिक शुरुआत करते हुए मैं पूरे सम्मान के साथ डायरेक्टर सर्च डॉक्टर अभय बंग सर को, संस्थान की निदेशक महोदया को और आयोजन समिति की सह अध्यक्ष डॉक्टर विनीता त्रिपाठी से अनुरोध करती हूं कि वे मंच पर आएं और अपना आसन ग्रहण करें।
Good morning, everyone. On behalf of Director CDRI, Dr. Radha Rangarajan, and the organizing committee for the Platinum Jubilee celebrations, it is my absolute honor and privilege to extend a very warm welcome to all of you. Today marks a moment of pride as we celebrate 75 years of CSIR-CDRI. CDRI was founded in 1951 under the visionary leadership of its first director, Sir Edward Mellanby. Sir Mellanby laid the foundation of a research culture rooted in scientific rigor and societal relevance. His ethos of integrating fundamental biology with applied drug discovery continues to guide CSIR-CDRI's vision and mission. Over the decades, CDRI has evolved into one of India's premier drug discovery and development laboratories, making significant contributions across infectious disease, metabolic disorders, reproductive biology, and oncology. The Institute has consistently strived to translate laboratory discoveries into affordable therapies, diagnostics, and technologies, while at the same time nurturing generations of young scientists and academia industry partnerships. It is our absolute privilege to welcome Padma Shri awardee Dr. Abhay Bang to our institute to deliver the Platinum Jubilee talk. So welcome. His pioneering work in community healthcare has transformed rural healthcare in India and stands as a powerful example of science in the service of humanity. We also extend a warm welcome to Dr. Satya Prakash Das, distinguished biotechnologist and COO of ABLE. He is well known for his sustained efforts in strengthening India's biotechnology innovation ecosystem. We are happy and grateful to have him as our guest of honor today. I also extend a heartfelt welcome to all our invited dignitaries, including the former directors, distinguished invitees, colleagues, students, members of the press, ladies and gentlemen. Many thanks for joining us on this historic occasion.
मैं निदेशक महोदया से अनुरोध करती हूं कि वे हमारे आज के अतिथि डॉक्टर अभय बंग सर का पुष्प गुच्छ देकर उनका स्वागत करें।
Okay.
कृपया जोरदार तालियों से सर का स्वागत करें। थैंक यू मैम, थैंक यू सर। अब मैं मंच पर आमंत्रित करना चाहूंगी निदेशक महोदया को, जो स्वागत भाषण के माध्यम से आज के कार्यक्रम की औपचारिक शुरुआत करेंगी। डायरेक्टर मैम।
Distinguished guests, heads of institutions, colleagues, friends, members of the press, and my dear students. A very warm and heartfelt welcome to all of you on this special morning of 17th of February 2026. It is a historic moment in time, the completion of 75 years as an organization dedicated to biomedical research and development. I consider it a privilege that all of us are here to witness the marking of this milestone. We will start the day with the CDRI Platinum Jubilee Oration. I extend a very special welcome to our speaker, Dr. Abhay Bang, and to our guest of honor, Dr. Satya Das, CEO of IKP Knowledge Park. We are really honored by your presence here. Our chief guest, Dr. N. Kalai Sedvi, DG CSIR, is on the way and will join us for the second half of the program, as well as the directors of our sister laboratories. I welcome Dr. Madhu Dikshit, former director CDRI, Professor Saraf, Director, NIPER Hyderabad, Professor M.L. Bhatt, Director, Kalyan Singh Super Speciality Cancer Hospital, and a warm welcome to our industry partners. As you all know, CDRI is a constituent laboratory of the Council of Scientific and Industrial Research and was formally dedicated to the nation on January 17, 1951, by the then Prime Minister of India, Pandit Jawaharlal Nehru. CDRI's mission is to develop drugs, diagnostics, and process technologies to make healthcare affordable in India. Over the last 1 year, we have organized various events marking our 75-year journey, many open to the public. In fact, today's talk by Dr. Bang is also being live streamed. Today, we cap the celebrations with the Platinum Jubilee Oration, followed by the Annual Day program. Our speaker for today's oration, Dr. Abhay Bang, is, like you heard, a Padma Shri awardee and Director of Society for Education, Action and Research in Community Health, Gadchiroli. He's an acclaimed physician, social activist, and public health researcher. Together with his wife, Dr. Rani Bang, he has pioneered a unique model of primary care centered around local priorities, community participation, and data-driven innovation. The improvements in maternal and newborn health, infectious diseases, and other health indices resulting from their work have transformed the lives of the rural and tribal communities of Gadchiroli. In fact, their model has now shaped policy and laid the foundations for sustainable healthcare delivery in rural India. For an institute like CDRI, which is commemorating 75 years of research and development, the learnings from such public health research must be our North Star. Unmet clinical needs need to be understood from a people's perspective and solved with people at the dead center. I know that Dr. Bang's talk today will give us great insights in this direction. So with that short introduction, I'll now hand it back to the anchors to take this program forward. Thank you all for being here today.
Thank you, ma'am, for setting the tone for today's Golden Jubilee celebrations. It is now time to introduce our speaker at length. It is my great privilege to welcome Dr. Abhay Bang, eminent physician, public health visionary, and co-founder of SEARCH, as madam just told you. Dr. Bang was deeply influenced by Gandhian ideals from an early age. Although accepted for doctoral studies in the United States, he chose instead to dedicate his life to social and health reforms in rural India. After completing his medical training at Government Medical College, Nagpur, he earned an MPH from Johns Hopkins Bloomberg School of Public Health, graduating as a gold medalist. In 1985, Dr. Bang, along with his wife, Rani Bang, founded SEARCH in Gadchiroli, one of India's most underserved tribal areas. Working across more than 150 villages, they pioneered community-based healthcare models that transformed rural health nationally and globally. Their landmark work on home-based newborn care reduced infant mortality from 121 to only 16. This model was later adopted by the Government of India and scaled nationwide through the ASHA workers, reaching millions of newborn children and saving their lives. Let us now take a moment to reflect on his remarkable life and work through a 2-minute short video. Please play the video.
हम सबके जीवन का कोई ना कोई उद्देश्य होता है। अपने लिए बनाया गया उद्देश्य सफलता देता है, अपनों के लिए बनाया गया उद्देश्य खुशी देता है। लेकिन
Hello. Yeah. So while that introduction would have been enough for a show like ABC, because we are standing in CDRI, I must tell you that he is not only a social reformer, but also a scientist and a researcher par excellence. So Dr. Bang has authored over 60 peer-reviewed publications, including multiple papers in the Lancet Journal. His research has revealed the hidden burden of gynecological disease among rural women. Dr. Bang has also led powerful public health movements, including the Mukti Path campaign to reduce tobacco and alcohol use in tribal areas. He has chaired the Government of India's Expert Committee on Tribal Health, producing the country's first comprehensive roadmap for tribal healthcare. While he has many global recognitions, some of the most notable ones include the Time Magazine Global Health Hero Award, the MacArthur Award, the WHO's Public Health Champion Award, the Gates Foundation's Goalkeepers Champion Award, and of course the most coveted Padma Shri Award by the Government of India. Sir, we are deeply honored to welcome you to CDRI today and look forward to your talk.
अब वो लम्हा जिसका सबको इंतजार है, खुद ही को कर बुलंद इतना कि हर तकदीर से पहले खुदा बंदे से खुद पूछे, बता तेरी रजा क्या है। अब मैं पूरे सम्मान के साथ आज के कार्यक्रम के अतिथि पद्मश्री डॉक्टर अभय बंग सर को रिसर्च विद द पीपल के संबंध में प्लेटिनम जुबली लेक्चर के लिए आमंत्रित करती हूँ। डॉक्टर अभय बंग सर।
This is fresh water.
ये में डाल लो। Thank you for that wonderful introduction. Those moments spent with Amitabh Bachchan was a great reminder. And I must begin by thanking Dr. Radha Rangarajan for inviting me to this prestigious institution to give this prestigious oration on the completion of 75 years of this institution. So first, please accept congratulations and compliment from a 75-year person to a 75-year-old institution. It seems that both of us were born in the same year. And it's absolute honor to be invited to deliver Professor Milan B. oration. CDRI's great contribution to the development of medicines and research is so well known that I need not add my further compliments. The topic that I chose today to speak with you is something which is not your daily experience. Your expertise, your field of work, your nature of work is very different than mine. And yet, both of us work in laboratories. I work in a community laboratory, you work in research laboratory. So I thought that some of our experiences and methods that we use and some of our lessons could be of use in developing the vision for some of the younger scientists in this institution. And I have titled it as Research with the People. And as you will see, what I intend to speak with you, okay, fine. I wish to tell you a story. I'm sure you'll be bored if I give you a preachy lecture. So I want to tell you a story. And then also, journey of 3 research studies which have something to contribute to an alternative research approach, which in the end, I wish to share with you. Now the story begins at this place. I don't know how many of you can recognize this place. Can you? Right. This is Bapu Kuti in Sevagram Ashram in Wardha district. 80 years ago, my father, who was a young professor of economics, he was a freedom fighter also, and he was selected by newly coming government of India for further studies in the US. His travel documents were made, his visa, fellowship, everything was ready. A week before his scheduled departure, he went to seek Mahatma Gandhi's blessings in this hut. Now, I'm telling you what I have heard from my father. I wasn't born at that time. This is year 1946. So Bapu was sitting on a bamboo mat and was writing something. My father went in. He bowed to him. Gandhiji knew him, so he asked him, Dr. Professor Bang, aap kaise aaye hain? So my father told him that, Bapu, I am released from jail and now I am going to the US for studying economics further. I want your blessings. So old man looked at my father for few seconds and then uttered only one sentence. He said, and he said it in Hindi, so I'll say in Hindi. अर्थशास्त्र सीखना है तो अमेरिका के बजाय भारत के देहातों में जाओ. And that's it. He continued his writing. My father quietly came out, and outside this Bapu Kuti, he tore away his admission and travel documents. And within 1 month, he with his young wife, my mother, went to live in a village called Barbadi to live like a farmer and study the true rural economics by living like a farmer. I was born in that village when my parents were living in Barbadi. So you can imagine that the direction of my life story really begins with this message of Mahatma Gandhi, go to the villages of India, which he gave even before my birth. So several decades later, when Rani and I returned from the US, having studied at the Johns Hopkins University, we naturally, Gandhi's words were still echoing in our ears. And so we decided to select a place which is least served by healthcare. And that's how we found Gadchiroli. But before we went to Gadchiroli, something happened which changed my idea very drastically. So I must share that story also. I had come to ICMR for some work, and I was staying in Delhi in a place called Gandhi Peace Foundation. And one morning, at the reception table, I was introduced to an old man. And unfortunately, I didn't pay attention to his name, so I didn't capture the name. But this man looked little like Mahatma Gandhi, curiously. So he asked me, तो तुम्हारा नाम अभय है? मैंने कहा हाँ. तो अमेरिका से लौटे हो? मैंने कहा हाँ. डॉक्टर हो? हाँ. तो मुझे हेल्थ की भारतीय व्याख्या बताओ. I was flabbergasted. During my medical education of MD and then public health subsequently, nobody had ever told me Indian definition of health. So I blurted out the WHO definition, which he of course rejected. He said, वो Western definition है. मुझे भारतीय व्याख्या बताओ. When I couldn't, he asked me, what is the Hindi or Sanskrit word for a healthy person in India? So I said, swastha. That is the Indian definition. जो स्व में स्थित है, वो स्वस्थ है. जो दूर स्थित है, वो दूरस्थ है. जो तट पे स्थित है, वो तटस्थ है, आकाशस्थ. वैसे ही जो स्व में स्थित है, वो स्वस्थ है. This was a eureka moment of my life. This was absolutely new viewpoint of looking towards health. Health is not more hospitals. Health is not more doctors. Health is not more medicine. Health is autonomy. Health is freedom from dependence. The word for health in India, it has inherently the very deeper meaning of what health means. So if that is what health is, how should be the healthcare system? And that's what we have been trying to discover and develop. Like you discover and develop drugs, we have been trying to discover and develop healthcare system which is swastha. I have coined a word for that. We call it Arogya Swaraj. Taking again Swaraj word from Mahatma Gandhi. And by the way, that old man looked little like Mahatma Gandhi because later on I came to know he was very grandson of Mahatma Gandhi. Professor Ramchandra Gandhi, who was earlier professor at Shanti Niketan, after retirement he had come to live in Delhi. So in a way, I learned this new meaning of health directly from grandson of Mahatma Gandhi. So a healthcare system where people are least dependent on others. People can manage their health affairs themselves. Individuals, families, communities. That's what Arogya Swaraj would be, and that's what our search in Gadchiroli. Now, I'll briefly take you to Gadchiroli because I'm sure you have neither heard nor seen Gadchiroli. Now, that red district at the eastern end of Maharashtra is Gadchiroli. It is red in every sense, not only in this diagram, but it is Naxalite affected area covered with thick forest. Near 80% of the land cover is, and then 1500 isolated remote hamlets and villages. Primitive paddy cultivation is the main occupation for 4 months, and rest of the months they collect various forest produce. The primitive transport with bullock cart, that's what was being used when we went there in 1986. Even sick patients, women, children had to be transported on bullock carts. And intermittently you heard bomb blasts because of Naxalite movement. Here in this Gadchiroli district, we established our headquarter campus, Shodhagram, a research village surrounded by tribal villages. Here we have our hospital, our research center, training center. We live with our 100 colleagues there, and we operate from Shodhagram. Now, this is the first study that I want to tell you about. Within few months of going to Gadchiroli, this young girl was brought to me. And though she was referred to me as a case of heart disease, I suspected that she had probably sickle cell disease. Till then, sickle cell had never been reported from Gadchiroli. So I had to establish the test, electrophoresis, and she turned out to be sickle. Now, in that enthusiasm, and imagine I was 35-year-old, fresh from the US, so you are very excited. Pahli case dhoond nikali, zile ki. So in that excitement, we did district sample survey to find out the prevalence of sickle cell, homozygous, heterozygous. And you know about sickle, this is how the RBCs look. And blood samples were collected from 3,200 individuals, tribals, non-tribals, and findings were shared in a conference chaired by the minister. And the minister hugely praised search, and he said that, look, this NGO came 1 year ago and they have found out this disease in the district. And he announced that a tribal medical research center will be started in Gadchiroli. Nothing happened. We got research publication out of a sickle cell study. I was given my first award, Adivasi Sevak Puraskar, by state government, but nothing happened for the tribal people. And when the Tribal Medical Research Center was established, it was established in Pune because researchers did not want to live in Gadchiroli. So the Tribal Medical Research Center went where the researchers wanted to live. They wanted to live in Pune. So we went to tribal people trying to coax them कि थोड़े आवाज कुछ बढ़ाओ अपनी, ट्राइबल मेडिकल रिसर्च सेंटर गढ़चिरौली में आना चाहिए. So they looked at us very blankly and they said, "Doctor, did we ever tell you that sickle is our problem? You came and asked for a drop of blood. We thought that young doctor couple है, इनको क्यों नाराज करे बेचारों को. So we gave you a drop of blood. We have nothing to do with this problem you called sickle. You discovered it, you solved it." That was the first lesson about research that we learnt in Gadchiroli. And what we learned from that is that research should address the needs of the community I work with and not the research community I report to. Whenever we think about research, all of us, we are all researchers here assembled, explicitly or implicitly, but we are thinking about research grants, research publications, and the conferences where we'll share our findings. So we are thinking about research community, but what about the community I live with? My research must primarily address their needs. And we decided since then, a principle for search, that hereafter we will not conduct any research which is not useful directly or indirectly to the local people of Gadchiroli, and we have stuck to that. So what are their needs? How do we know? We started going to tribal villages, sitting around night fires, talking with the tribal people and asking them what their needs were. And then we organized People's Health Assembly, tribal representatives from 50 villages assembled, and then we asked them, what are the topics on which you want us to conduct research? And after 3 days discussion and thinking about several health problems, through a process of ballot box, they selected for us following problems. They said, ये हमारी समस्या है, इस पे कुछ कर सकते हो तो करो. Malaria, very endemic in Gadchiroli. White discharge amongst women, white vaginal discharge, so common amongst women, but nobody used to talk about it. Alcohol and alcoholism amongst men, child mortality, and backache. Now, these are the research priorities that they gave us to us. For the past 30 years, we are working only on these problems. We have done nothing more. So I'll share the journey only on one priority. They said, हमारे बच्चे मर जाते हैं, आप कुछ कर सकते हैं क्या? It was a very, very moving request. And you heard in KBC that I talked about the child's death. And so what could be done about child death? So we selected laboratory of 102 villages. This became our population or community health laboratory and established a system by which every birth and every death will be recorded. And we, through a process of verbal autopsy, we started determining the cause of death. Why did children die? In the first year, in 1988, when we first started this measurement, IMR, infant mortality rate, those who are not accustomed with this term, if 1,000 children are born alive, how many die within 1 year? That is called infant mortality rate. So we found that IMR in Gadchiroli was 121. Just for comparison, at that time, Kerala's IMR was 15 and American IMR was 6 and Japanese IMR was 4. The IMR in Gadchiroli was 121. And the causes of death that we assigned for 1 year, we found that pneumonia was number 1 cause of child mortality. Now, what could be done for pneumonia? When a child or infant in rural area develops pneumonia, it becomes very breathless. And the respiratory rate goes up, subcostal indrawing develops. Now, those children, they hardly ever reach hospital. They develop pneumonia there, they gasp for air in those huts and they die there. And at that time, globally, 5 million child deaths were occurring every year because of pneumonia. 4.9 million diarrheal deaths and 5 million pneumonia deaths. So pneumonia was globally recognized as cause of number 1 for child mortality. Now, using the respiratory rate, Frank Shan, a pediatrician in Australia who went to Papua New Guinea, another tribal area, and while working there, he did this very simple but brilliant clinical research, and by way of which he showed that in a child with cough, if you count respiratory rate, in a neonate, if it is more than 60, and in an infant, if it is more than 50, it is most likely pneumonia. High sensitivity, moderate specificity, but this was a very useful research because then without stethoscope, without X-ray, you could reasonably diagnose pneumonia in children. Now, how do I take this to the people of Gadchiroli? Because the rural women whom we wanted to teach this, they couldn't even count up to 50 and 60. So I developed this simple child toy looking instrument. I call it breath counter. There is a 1 minute sand timer. So even if the woman doesn't have wristwatch, which they didn't have in those days, turn it upside down. When she has a child with cough, her own child or somebody in the village, turn it upside down and then count respiratory rate, count the breaths. Most of the women could count up to 10, not more than that. So for every counted 10 breaths, she would move one bead. She would select the row depending on the age of the child. There are photographs of the children, but they have become faint now. So if it is, let's say, infant, she starts moving the beads depending on the counted breaths. She counts from 1 to 10 and then moves one bead and then again starts counting 1 to 10. She doesn't know what is 30, what is 40, what is 50. But if the red bead is moved before the sand has passed, most likely this is pneumonia. I compared this on 50 children with cough. I using my stethoscope and women using, she is Yashoda Bai, a TBA, traditional birth attendant from a village called Bodli. She is illiterate. She cannot count more than 12. 12 because British zamane mein dozen hua karta tha. So old women know what is dozen. So within her ability to count, within the limits of her numeracy, breath counter allows us to diagnose pneumonia in a child. And when I compare TBS diagnosis using breath counter and my diagnosis using stethoscope, 82% of the time diagnosis matched. Not bad. Turning a village woman into a person capable of diagnosing pneumonia. And when they diagnose pneumonia, treated with oral antibiotic, oral cotrimoxazole, and look at the effect on case fatality. Before this was introduced, the case fatality in children with suspected pneumonia was 13%, 13.5%. Then with treatment becoming available, it dropped to less than 1%. And this also had enormous effect on infant mortality rate. The IMR in that 102 villages, we divided those 102 villages into intervention area and control area. In the 58 intervention villages where it was introduced, this intervention through rural trained community health workers and TBS, IMR dropped from 121 to 76. This study was published by the Lancet in 1990, and it provided major inputs for the global ARI control policy. ARI is acute respiratory infection in children. So global ARI control program, when it was developed in Washington in 1993 conference, the Gadchiroli study provided the main input as to what is the evidence and how pneumonia can be managed and mortality reduced globally in the developing countries. Now our next challenge, remaining challenge, you saw the IMR having come down from 121 to 76. What was this 76? Mostly it was contributed by neonatal mortality. Out of 76 deaths, 60 came from newborn babies. And a newborn baby in a village is a very vulnerable, weak human being. At the highest risk of mortality, throughout the human lifespan of, let's say, 60 or 70 years, the risk of death is concentrated at the early 1 month and latter few years of life. So this is the very risky period. Globally at that time, 5 million neonatal deaths used to occur every year. In India itself, 1.5 million neonatal deaths. Every year, 26 million neonates are born in India. But they didn't reach anywhere to the source of healthcare. And they were usually born in rural areas, in this home delivery room, which used to be a dark room where nobody else was allowed to go in except for the TBA, traditional birth attendant, and the grandmother. If babies became sick, if mothers became sick postpartum, no way to go. Tradition did not allow them to go out of that room. Nazar lag jayegi, jadoo tona ho jayega. So postpartum woman or a newborn baby were not allowed to leave that room. They were not allowed to cross that doorstep. And so those babies were born there. 2 crore babies in rural areas were born in those home delivery rooms. They were taken care of there, and they either survived or they died in those dark rooms. Hospitals were there, but they were 200 kilometers away. And though WHO and UNICEF guidelines said that a sick newborn is a very serious condition, so immediately referred to hospital, but where was the hospital? And how could that baby be allowed to go to the hospital, which is so far? And so we thought that if babies cannot reach hospitals, medical science must reach where the babies were. And they were in those home delivery rooms. So newborn care must be made home-based newborn care and not hospital-based newborn care. And with that, turning the science of neonatology upside down, we designed this home-based newborn care model with the goal to reduce neonatal mortality using the human potential available in the village. And though I use the word human potential, I really mean woman potential in the village. And then we designed a field trial, controlled field trial with 39 intervention villages and 47 control villages. In the control villages, regular government programs continued. In these 39 villages, we introduced home-based newborn care model delivered. As you can see, for the first 2 years, 93 to 95, we measured the baseline mortality rates in those areas. And the baseline IMR was 76 and newborn mortality rate was 60 during 93 to 95 phase. Both the areas, it was almost equal. And then home-based newborn care was introduced in the intervention 39 villages from 95 to 98. Now she is Kajubai. Kajubai is a Dalit woman from village called Ambeshivne. 7th failed. Husband alcoholic. He died of tuberculosis subsequently. Now Kajubai was though Dalit woman, young woman, but she had that spark in her to do something for her village and something to raise her own status, her own abilities. We selected Kajubai as the community health worker. We called her Arogya Doot. So 39 community health workers were selected from 39 villages, 1 per village. And then they were given training of hands-on training, how to work in the village, identify pregnant women, give them health education, how to examine newborn babies, identify sicknesses, make home visits, 8 home visits to every newborn baby, weigh the baby, measure the temperature. Here, the community health workers are learning how to resuscitate a baby which is not breathing at birth, birth asphyxia, So they are using ambu bags, which anesthetists used to use in earlier era, and trying to resuscitate baby. And everybody, look at the curiosity in their eyes. Even though they are semi-literate rural women, but their willingness and keenness to learn is no less than ours. And if the babies, twin babies, low birth weight babies, premature babies, how do you take care of them? There were no incubators, there was no electricity. So this is how they were covered and they were taken care of. And if babies develop signs symptoms suggestive of newborn sepsis, which is a very fatal condition. In the pre-antibiotic era, there are studies from the US, 90% case fatality in case of neonatal sepsis. And so with the presumptive set of clinical signs and symptoms, which we validated against the diagnosis of Vinod Paul. Vinod at that time was professor of neonatology at the AIMS Delhi. So particular set of sign symptoms, clinical sign symptoms, which even Arogya Doot could record and detect, how could she be able to diagnose sepsis? This we have subsequently published in international journals, but using that clinical algorithm, he was able to diagnose neonatal sepsis without culture and treat with antibiotic. Now look at the effect. The outcome, intended outcome was to reduce NMR, neonatal mortality rate. 1,000 babies born alive, how many die within first 1 month of life? That is neonatal mortality rate, NMR. Now here it is about 10 years data. And the yellow line is the NMR in the control area, which was government program area, where we only retrospectively collected mortality data. You can see that from 93, it was around 50, around 60, with some annual random fluctuation. But for 10 years, the NMR in control area has remained at or above 60. And the control area actually represents the whole of India in a way, because nothing happened in the rural India for NMR for 10 years. And the blue line that you see is the NMR in the intervention area. To begin with, it was 62. And with the introduction of home-based newborn care in 1995, it steeply dropped and dropped and dropped. And in 3 years, it came down to the level of 26. 62% reduction in the NMR. And then our research trial was over there, but we continued this as a service program. Ethically, we couldn't withdraw that once it was so successful. So we have continued, even till today, we have continued home-based newborn care in those villages, 30 years later on. And so you can see that from research mode, when it went to the service mode, the NMR was still less than 30. So 70% reduction as compared to the control area. And now if we go back to the infant mortality rate, in 1988, the IMR was 121. With the introduction of pneumonia case management delivered by community health worker, it came down to 80. And with home-based newborn care, it came down finally to 26. And so and the less than 30 IMR that was achieved in Gadchiroli, I'm sure it is mere coincidence, but we achieved that in Gadchiroli in 2003. And in 2004, when the new national health policy was designed, this was the national goal, reducing IMR of India to less than 30. And poor Gadchiroli had already achieved it. Who did this miracle? These are the 4 women. The old woman that you see on your left side is traditional birth attendant, then grandmother, mother, and the trained Arogya Doot. Now these 4 kind of women, and you can see it, 2 preterm babies they are taking care of. Now look at them very carefully. They have done a huge miracle, reducing NMR and IMR. In the US, reducing NMR is so difficult. If some new intervention, vaccine or drug or diagnostic, if it reduces NMR by 5%, it would become national headline and the stock market would go up. And here these women have reduced it not by 5%, by 70%. So look at them little more carefully. What is special about them? The only thing special about them is that there is nothing special about them. They are as ordinary as millions of women in rural India or Bangladesh or Pakistan or Africa or South America. World over, such 2 billion women are waiting. Come and give us some knowledge power. And we will become swastha. We will be autonomous, sovereign in taking care of our own health. Same Kajubai, 20 years later, her hair has grayed. But look, this is what they have. Arogya-Doot, trained Arogya-Doot. Some few preliminary equipment for newborn care, measuring weight, measuring temperature, counting respiratory rate with wristwatch, records and medicines. 1,500 rupees, that is the cost of the equipment that Arogya-Doot carries. And those all equipment can come in the shoulder bag, Shabnam bag. So with those equipments on her shoulder and training, knowledge in her head and skills in her hands and compassion in her heart, the trained Arogya-Doot can become a mobile neonatal care hospital. And I'm not exaggerating when I make this statement, because the National Neonatology Forum of India, NNF, they selected 13 hospitals from India, and the NMR of those hospitals and NMR in the villages of Gadchiroli, where care was provided by this community health worker, is very similar. For preterm babies, for low birth weight babies, for the different levels of birth weight, the mortality rates in secondary level hospital and villages of Gadchiroli, where these women provide home-based newborn care, they are comparable. So home-based newborn care does not mean poor quality newborn care. The quality is as good as secondary level hospital. And the inputs required, the cost required is very low, and it basically depends on empowerment of women. This is the logo of home-based newborn care that I designed. That hut was dark. That woman is alone there, responsible to take care of her baby and save the baby. But open that one window of knowledge, window of opportunity, and that woman becomes empowered, and on her empowered hands, she can take care of the baby at her bosom. So home-based newborn care is really empowering people, empowering women to take their own health and healthcare in their own hands, in their empowered hands. This study was published in the Lancet in 1999, but not only that, subsequently when Lancet published its special volume called the Vintage Papers from the Lancet, from the 180 years history of the Lancet, they selected papers what editors thought that were the milestone papers ever published in the Lancet. And if you flip those pages, there are papers by Louis Pasteur, and there is Ronald Ross paper on discovery of malaria, and there is a paper by Benting and Best about discovery of insulin. And when you come to 40s, paper by Alexander Fleming on discovery of penicillin. And when you come to 90s, there is a paper from some obscure place called Gadchiroli, a paper on home-based newborn care. This particular approach made a lot of waves world over. This study was repeated first by us in different parts of Maharashtra, then by ICMR in 5 states in India, then by Johns Hopkins University in Bangladesh, by London School of Tropical Medicine in Africa. Everywhere it was found that it is feasible to deliver home-based newborn care and that it was effective. In 2011, the Planning Commission in 10th 5-year plan and subsequently in 11th 5-year plan selected Gadchiroli model as the national model to reduce NMR and IMR in India. ASHA program was partly designed on the Arogya Doots that we had developed in Gadchiroli, and we were asked to develop training system for ASHAs. So we developed a training system, training modules and training of national and state trainers who train district trainers, who train 10 lakh ASHAs. So now 10 lakh ASHAs all over India have been trained to deliver home-based newborn care, and India's IMR reduction. Prakash Jha has published a paper in the Lancet as to story of reduction of IMR in India. These 5 years, 2010 to 2015, these are the 5 years where the IMR in India declined the fastest. This is exactly when the ASHAs had started delivering home-based newborn care. And last year, the health ministry informs me that 15 million rural neonates received home-based newborn care delivered by ASHA. The Prime Minister, in one of his Man Ki Baat programs, he talked with all ASHAs in India, nearly 1 million ASHAs. And he, of course, said whatever he wanted to say. But then he asked question, and one ASHA from Jharkhand stood up and he told him the story that baby was born and she was not breathing. So how I resuscitated the baby, and Prime Minister asked him, where did you learn this? She said, from Search Gadchiroli. So this has become now a national model, and those 20 million rural neonates that I mentioned, they were born in home delivery room. Of course, now gradually more and more deliveries are occurring in hospital, better, much better for women. But then when baby returns home, whether it is low birth weight, preterm babies or normal baby, ASHA continues to provide home-based newborn care. And finally, UNICEF, WHO, USAID and Save the Children, they published a global document that if the hospital access to hospital care is not possible, then home-based newborn care is the best way of taking care of newborn. So from Gadchiroli to global, that is what is the journey of this one. Newer priorities are emerging in Gadchiroli, and non-communicable diseases are emerging, and addiction and mental health problems. But our search for community-based solutions, how can we empower and give solutions in the hands of community, that continues. So having told you those stories, I want to do some reflection with you. Whenever a young researchers come out of an institute, of their training, university or some institute, the first question that everybody faces, where should I do research? कहाँ जाएं? कहाँ research का मौका है? So, based on whatever I shared with you and from what Gandhi said, go to the villages of India, my advice is go where the problems are and not where the facilities are. Places with facilities don't need you. There are so many people waiting there in a long queue. वहां तो आप प्रॉब्लम है, आपका क्या करें, क्या काम दें आपको. So instead of crowding in those facilities, go where the problems are waiting. Nobody wants to go there. Look, it's very easy to become a pioneer. The Lancet has, in one article which was published on Rani and me, they have called us pioneers of healthcare in rural India. But I want to share this secret with you, how to become a pioneer. बस जहां प्रॉब्लम है वहां जाइए. If you are standing in a long queue of research or career, you are at the end. I don't know how much chance you stand up becoming first in that long queue, but Vinoba has given one very master stroke solution. He said, in such situation, turn around and the whole world, whole queue will be behind you. Just change your goalpost and select a goalpost which others people don't select. And that is the trick. There are enormous number of villages and places in India where people are suffering from n number of health problems, and India is awaiting for solutions. You are developing several such solutions here in the CDRL, but I am talking about situation in the community. So these problems need solutions, and you can become the pioneer by selecting problems which are waiting there to be solved. Don't go after the journals in the US and UK and Europe, because they have already done that research and they are 50 years ahead of us. Whatever you do, you will always be only you will do only research. What is already discovered, you will repeat it. So what? आप क्यों में आखिर ही रहेंगे? That's the historical reality, because they have the equipments and money and everything. They have their lead in research, but they don't have problems and communities that we have here. So what is our strength? Our strength is our people. And people need solutions. And when we asked them, they gave us those 5 problems for research. I'm little going back to that story. But out of that, those 5 problems, of course, malaria is well known, and child mortality was also global priority at that time. But nobody was talking about backache or gynecological problem of women or alcoholism. Now, if you look at the global burden of disease study, the largest ever public health study in the world, they have identified these as the main causes of loss of life years over the world, and the risk factor. Tobacco and alcohol are the 2 of the top 7 risk factors contributing to global mortality and morbidity. People told us 30 years ago. Once when I presented home-based newborn care at the WHO headquarters in Geneva, year 1999. So the WHO chief of maternal child health asked me, Dr. Bang, how come it happens that you are able to find a problem and solution 10 years ahead of us? Earlier, I didn't share that, but earlier we had done a study of hidden burden of gynecological problem in rural women. And then it led to women's reproductive health change in global population policy. It was one of the evidence which contributed to that. And then we developed pneumonia management method, which shaped the global policy. And then this was HBNC. This was too much for him. ये कौन सा गढ़चिरौली कहाँ का है, कौन छोटा सा ऑर्गेनाइजेशन है सर्च, और ये बार बार हमें, तो he asked me how do you manage to do it? So I said to him that I can't say that we are more intelligent than you. You are the cream of the world. WHO, Geneva headquarters. Everybody aspires to come here. So only advantage we have is that we are 10 years nearer to the people than you are. And that is the advantage that all of us in India have, that we are nearer to where the problems are, where the people are. We should turn that advantage into our strength. Go to the people and ask them, भैया आपको क्या चाहिए? तो वो आपको कहेंगे कि सिकल सेल हमारी प्रायोरिटी नहीं है. उन्होंने हमसे कहा कम से कम. National programs are designed which not necessarily always are people's priorities. Tribal people told us that वो सिकल आपका आप रखिए, हमारे problems ये हैं. Where should I conduct research? Go that we discuss actually. And how should I identify research problem? That's the next question. मेरे thesis का topic क्या हो? मेरे research का topic क्या हो? Listen to the people. I already shared with you what is the power of listening to people. You mentioned about that Time magazine selected us as the global health hero. So when their Asia bureau chief had come to write a story on us, he wrote a story on us, but he titled it as The Listeners. I was not very impressed. Listeners doesn't sound very great, isn't it? So I protested mildly कि ये क्या title दे दिया. So he said, Dr. Bang, you don't realize. You are very unique that you listen to the people. Doctors लोग सुनते नहीं हैं. And no researcher, he said that I do not know any researcher who has gone to the people and asked them, tell us on what problem we should conduct research. So your uniqueness is in listening to the people. Okay, bhaiya. So listen to the people. People can give you very important inputs. 30 years ahead of the global burden of disease study, people have virtually told us that these are the problems. Apart from listening, observe, collect epidemiologic data, and based on data, select the problem for research. How should I conduct research? And this is little sensitive issue. When a research is done, the researcher gets the grant, researcher gets the publication, researcher gets recognition and opportunity to speak like I am speaking with you. But what about the people? What do they get? Do you know that famous or infamous picture published in 1992 as the cover story of Newsweek? A child in Ethiopia, very malnourished, tired, sitting alone in a desert, about to die, and there is a vulture sitting there waiting for this child to die. If you remember that photograph, it received the global award, the best picture award of that year. But then the story doesn't stop there. The photographer committed suicide after 6 months. What could I do for that child? And that child and such children in Africa continued to die. So out of depression, he committed suicide. So this is the ethical question awaiting all of us. That what do people get out of my research? Can there be a research approach by which people are also enriched? People are also empowered. They may not get money, but at least knowledge, power, and some solution. So I have created this framework about research, 4 types of research or 4 research on the people, where researchers use people as guinea pigs. And I am ashamed to say, but this is what our research on sickle cell, it was research on the people. People didn't need it, people didn't benefit it. I received the award, I received the publication, but people didn't benefit at all. It was research on the people. For me, people were objects on which I conducted research, though we call subjects, but they were really objects. The next stage of research, better than that, is research for the people. Research which helps people, research for the people. Not irrelevant, but addressing people's needs. Third would be research with the people. If it is possible, involve people in selection of priorities, conduction of research, and delivery of intervention. And then finally, this is my dream, research by the people. A day would come when ordinary men and women of India and the world over will be so knowledge empowered that they'll be able to conduct research on their own lives. And it's not impossible. It's not a very impossible dream. But this could be the 4 stages, a ladder of research, the ethics of research ladder. After that sickle cell study, we have never done that kind of shameful study. But then we have been doing research for the people and research with the people. And as I said, we are waiting for research by the people. Now, research with the people, its characteristics are people should need it. People should understand it, what research is being done. People should participate in doing it, delivering it. People should use it. And finally, people should own it. And in the hindsight, yes, the home-based newborn care or pneumonia, or most of the research that we have been doing in Gadchiroli stand to those 5 tests. Now the question is, will it produce impact? or will it remain only in Gadchiroli? Now remember, about 2000 years ago, that old scientist called Archimedes, he told his emperor that give me a liver long enough and a place to stand outside the earth, I promise you to move the earth. With his weak hands, old Archimedes boasted that with this kind of liver, he can move the entire earth. Of course, people laughed at that time, but we know that he was correct. Through the physics principle, we know that through the principle of liver, it is possible. So organizations like Search, small, weak, impoverished, we don't get many professionals to work in Gadchiroli. But then we are standing outside the earth, outside the mainstream. But mainly it is the power of the research. Research or generation of knowledge and evidence has its own enormous inherent power, that it can move the knowledge emperor sitting in Geneva or New York or London or Washington. Sitting in Gadchiroli, we have at least repeatedly fired knowledge missiles on these capitals of knowledge and changed the ideas and changed the policy. It's not our power, it's power of knowledge, it's power of research. And anybody in India should be able to do it. Research with the people is that power. When you identify a problem with the people and do research which can be delivered by people, through people, for people, Gadchiroli can shape the global policies. Now, finally, something which all of us are struggling with, and that is how to provide accessible, affordable health care to 1.4 billion people of India. That is the large challenge, all, whether CDRI or Search or ICMR or all of us are really, ultimately, this is the challenge we need to address. Living in 1 million villages, hamlets, towns, slums, how do we provide health care to this huge population? And the medical care model, which we are right now trying to imitate, is the American model. Medical insurance, private care, professionally heavy, technologically heavy, cost-wise heavy hospital care. Now, look, where does that model lead to? The US medical care cost, this is per capita per citizen. This is not patient care bill. This is average per capita healthcare cost in US today is $10,000 per capita per year. Almost 10 lakh rupees per capita per year, while India spends 6,000 rupees per capita per year. And you are trying to imitate a model which is 10 lakh rupees per capita per year. It's impossible. With this medicalized hospital-based model, you cannot manage non-communicable disease epidemic in India. So we need some other way of providing health care. The best way of providing universal health care, 1.4 billion population of India, is to generate universal capacity to care for health. And that is Arogya Swaraj. Where people are empowered to take care of their own health, there is no other solution. Like livelihood has to be earned by everybody. Governments cannot feed everybody eternally. So Swavalamban, Atmanirbharta in healthcare. And that doesn't mean Atmanirbharta of India. It means Atmanirbharta of every individual. Swastha. So our direction has to be towards Swastha. And this is what we are still trying to search. Few pieces of knowledge, few pieces of jigsaw puzzle have been found, but there is a lot of ground to cover. And newer diseases and priorities keep on emerging. And we continue to, this is logo of Search, by the way, trying to find path in the forest of Gadchiroli. Thank you so much for inviting me and let me have this dialogue with you. Thank you, sir.
Ladies and gentlemen, thank you very much, Dr. Bang, for that remarkable talk and for providing us with a glimpse of your life's mission and vision. Sir, your life exemplifies how rigorous science, compassion, and community partnership can transform health systems and change millions of lives. Sir, you will be happy to know that CSIR and CDRI has started an outreach programs to reach the underprivileged people in and around our institutes and go and serve them where the healthcare facilities are not available. Sir, today you have inspired a whole generation of youngsters to pursue science with purpose, to serve society with humanity, and to believe that meaningful change begins at the grassroots where the people are. Thank you very much indeed. And please join me in thanking him again for his wonderful talk. Dr. Radha, I now request you to kindly felicitate Dr. Bang.
थैंक यू मैम, थैंक यू सर। अब मैं आमंत्रित करती हूँ आयोजन समिति की सह-अध्यक्ष डॉक्टर विनीता त्रिपाठी महोदया को कि वो यहाँ पे मंच पर आए और धन्यवाद ज्ञापन प्रस्तुत करें। डॉक्टर विनीता त्रिपाठी मैम।
ये रह गया।
Good morning, everyone.
But before that, there's it's a portrait made.
Who looks smarter, this or this? Thank you, sir. Beautiful.
Good morning, all. Dignitaries on dais, Padma Shri, Dr. Abhay Bang, Director Ma'am, honored guest, faculties, staff, and dear student. This is my privilege to offer this vote of thanks as we mark the historic milestone of our Platinum Jubilee. Today, we have been moved and mentored by a true pioneer in public health. So, your lecture or research with the people has been more than an academic discourse. It has been a call to our conscience. You have shown us that most sophisticated science is that which serves the most vulnerable, and the true research is not just about studying a community but serving it. Your journey from Gadchiroli to global stage is a guiding light for every aspiring researcher present in this room. On behalf of entire CDRI family, we thank you for gracing our event with your presence and inspiring us. Thank you very much, sir. On behalf of organizing committee, I extend my sincere gratitude to our director madam, for curating this Platinum Jubilee talk. Madam, it is through your leadership that we are able to learn from the legend like Dr. Bang. We also thank you for your guidance, timely advice, and support, ma'am. A huge thanks to the entire organizing committee, chaired by Dr. Amir. Events like this involve months of silent work behind the scene. Your efforts have ensured that today's session ran flawlessly. I appreciate our volunteers and backstage crew for making sure that every detail has been taken care of for smoother execution. I also extend my thanks to the colleagues from administration, finance, and purchase for their timely help and support. We thank our technical team and ground staff, including security and housekeeping, for their dedicated work, ensuring that every corner of CDRI was ready to welcome our guests. As we conclude the first session of today's program, I want to thank you, everyone present in the auditorium, for their enthusiastic participation. Thank you. Have a great day.
डॉक्टर अभय बंग सर का, निदेशक महोदय का तथा आप सभी का सहभागिता के लिए बहुत बहुत धन्यवाद। 11:15 पर हम लोग पुनः असेंबल होंगे यहाँ पे। प्लेटिनम जुबली का लेक्चर अब यहीं पे समाप्त होता है। थैंक यू।